It's a bright Tuesday afternoon, an important afternoon and week ahead after, of course, the twin workshops, where I can say one which is on pain, making a different perspective to evolve our perspective and our experiences related to the pain. And the second one was aptly acupuncture, which we are all aware that it has multiple mechanisms. Ritu Sani ma'am joining us on the screen now. Yes, ma'am.
Good evening, sir.
Yes. So the pain course definitely would have taken your understanding of the pain to the higher level, and how different interventions targeting multiple regions or multiple stimuli. Okay. If we give only one stimulus like tightening the thigh quadriceps, okay, it's a local effect. Whereas if we tell with relation to, of course, the foot and ankle, because today we have the topic as the twin webinars for the foot and ankle. So we would like to begin either with the plantar heel pain or with the lateral ankle sprains. Okay. So in this foot and ankle also you see that gastrocnemius stretching. We have been doing that for a long time, where patients are lying down supine, do the dorsiflexion, okay, and you will find that gastrocnemius tightness is there in patients who do not have pain also, and those who have pain also they are having that, okay. And you might think that heel pain is there right side, the gastrocnemius is tight, so I will stretch, but the left also gastrocnemius is tight only, but the left do not have any pain at all, okay. So we as physical therapists, we should be highlighted on, like, we should not do a treatment just because it has been done so many years. We must stop all that protocol based interventions and rethink, are we really pathomechanically treating the patients? And pathomechanical in terms of the dysfunctions, because how the dysfunctions leads to pain, or how the dysfunctions aggravate the pain, how the dysfunctions maintain the pain. That is what is the pathomechanics. Okay. All of us have dysfunctions. All of us have pain. Which pain has to be treated and how it has to be treated? What should be the focus when we treat it? For example, even a heel pain, whether our focus is on the heel or the focus is on the heel pain during which activities, so that we focus on the activities part. Not everyone requires a surgery or corticosteroid injections, okay, when it comes to plantar fasciitis or any other all these conventional terms for the heel pain. So you give us the intro of the clinical scenario on the plantar heel pain, what you have understood about the pathomechanics in your experience, so that we get on with more information, as we are also anticipating Dr. Sujanya to join us. Yes, ma'am.
Yes, sir. I think it's a very common condition which, as a clinician, we see in our patient, because some patient complain that after walking, they feel pain in that plantar area, the heel pain they feel, or in the early morning when they keep their first step to the floors, that time they feel the pain. They feel that very uncomfortable shooting pain like condition, and they are not able to keep their foot on the floor. After that, sometimes when 4 or 5 or 10 steps, they feel little comfortable. So this scenario they always explain like about this. And some patients say that when they go for the morning walk and evening walk, during the walking they don't feel any pain, but when after they finish their task, they finish their walk and they come and sit, after that they start pain at that area in the plantar area. So this is these symptoms they explain after that. So it means that over use of that area, the fascia, connective fascia of the plantar, that area they are having some inflammation like condition, or they feel pinching pain condition like, and also they are feeling the pain in the heel area, and also in the calf muscle also there is a tightness, or maybe like because of the trigger point in the gastrocnemius, or weakness or the tightness of calf muscle. So they feel pain, and sometimes while doing the movement dorsiflexion, they are not able to do actively that dorsiflexion. They feel the pain in the dorsiflexion also. So this type of condition, as a clinician, we see in the clinic. But as the part of the AMPT, what we are learning according to the pathomechanics, we not only focus on that, we will not only provide the electronic modalities and ultrasonic or hot and cold baths, which they normally people say that you do this and after that you will feel the comfort. But in our domain, we always check that what is the cause of the patient, what activity is restricting them because of this pain. So this is our view. So if they are having, when they are loading their foot on the floor, that time they feel pain. So it means we have to see full kinematic or kinetic chain of the lower extremity with the relation to the knee. Either their knee in the internal rotation of tibia or external rotation of the tibia, which is already associated with the pronated versus supinated foot. So that is also very important part which we assess, and we see that if the patient is having a plantar heel pain after their fascia, that is the flat foot, which we see the flat foot, and the pronated foot is also, and some are having hyperpronated also. So this is the things which we evaluate, that either their foot is in the pronated position. So, and this is the fascia, which is the connectivity of this sheath, which is the fascia. If there is a tightness in the HLS tendon also, like this is the, I have measured it like that, this is the tendon. So if it is also tight, so it will also uh, give effect to the working of the plantar fascia, and the inflammation in this fascia itself give the patient, they are not able to do their actively their toe extension of the toe is also affected when the patient is having a plantar heel pain. So either with the weakness or the tightness of the flexor hallucis longus, or maybe we see the dorsiflexors, because there is a plantar flexor, they are not able to do their activity, they will affect the dorsiflexor also. So when the patient is keeping their foot on the floor, so that time the dorsiflexion is affected, so they feel pain. So this is the mechanics which we check in the standing position itself, because we know that if the foot is in the flat position, so definitely this medial arch is, which is giving the arching to the foot, it is also affected, because this is also flat. So we have to see what are the structures, either there is a compression or the stretch to the other side. So this is the full picture, because in plantar heel pain, we know the pronation, the pronated foot is the first picture, flat feet is the second picture we see, and as well as we see that the patient is having a also the abduction of the foot, or as well as there is a eversion, or as well as dorsiflexion. So these are the condition which we see in the foot, and after that we see that according to the muscle imbalances, posterior compartment versus anterior compartment, which are the, either they are the muscles are in the tightness, or they are the muscle they are weak, so they are not performing their activity. So releasing that muscle on the foot is also very important, and till the knee to the foot, the muscle, the posterior compartment versus anterior, or medial or lateral also, because we know that the peroneus group muscles can also be give in this create a problem. So we have to check all these, either there is a trigger point in that area, or because of that the tightness of the Achilles tendon, so this tendon is tight, so we have to work on that tendon also, or we have to give the myofascial releases on the fascia also, because there is the adhesion, there is the sometime trigger point are also there. So we have to release that fascia also, because we know that this is completely related to the connective sheath. So connective sheath means we have to focus on the facial part also, and as well as a AMPT, we never release the fascia alone, we work the myofascial component, the muscle contraction, then we release the fascia. So this is the way which I understand about the plantar fasciitis according to their structural postural problem, they are imbalance related to the posture and imbalance related to the muscle activity or whatever the structure, the ligaments which are medially versus the laterally, which we see either there is a instability, because of that the patient is having overpronated foot. So these things which we see in our patient, and according to all these things we have to check all the structure, articular, myofascial and neural, so which we never forget to check all the either the, there is a problem related any neural component, so the patient is having a problem, because we know that the medial side how the tibial nerve plays a very major role, and we have to check all these things and then we go further for our treatment. Yes, sir. Over to you, sir. Sir, your screen is completely hazy.
My screen is hazy. Sujanya, are you
Yes.
able to see me?
So Janya
Hey,
ma'am, screen is fine.
yes, sir, your screen is a bit blurry, hazy, yeah.
Now?
Better, little better, but still, but better than before.
Obviously, when two bright women are sitting in front of me, how can I be bright? Okay.
Thank you for the compliment. We take it.
But after giving the compliments, our screen is perfectly fine now.
See, that's the
Uh,
power, that's the power of women.
okay. Especially when they are synced and they are, what to say, together. Okay.
High five, right?
Otherwise,
Between high five.
yeah. Okay. So it's nice to have even many of our friends from across the world. Plantar heel pain. Okay. Plantar fasciosis, fasciitis, calcaneal fat pad syndromes. Um, maybe even a tibial nerve, okay, or the sural nerve entrapments, like tarsal tunnel syndrome, that is medial side entrapment, that can also cause the medial heel pain. Sural nerve irritation or mechanosensitivity issues will cause lateral part of the heel pain. Calcaneal fat pad syndrome causes heel pain after prolonged standing. And the plantar fasciitis is actually typically a overuse injury, which is like to do with improper footwear, uneven grounds, limb length discrepancy, either structural or functional discrepancies, and basically related to a deconditioning, okay, in our lifestyle. And those patients develop this plantar fasciitis. Previously assumed that it was inflammatory, so plantar fasciitis. Later, people realized that there is no inflammatory, pro-inflammatory substances, nothing is present. So they delineated it as degenerative, and that degeneration is confirmed by the early morning symptoms, where Rita ma'am also highlighted that the few steps that we take, okay, so that is the sharp pricking pain, or it is the stretch with the pricking pain during the heel off phase of gait. So conventional treatments, as madam was highlighting, was focusing structurally. Okay, mainly they focused on plantar fascia releases, treat the local inflammation with modalities that can optimize that, whether it is thermal or it is electrical. And the exercises were again specific to like stretching the gastrocnemius, okay, or strengthening the intrinsics of the foot, which were all very structural. And madam highlighted that functional perspective of including the hip and the knee, because without them, foot is not getting what to say, the reason actually why it is going for injury. Okay, it is like, for example, we three of us are here. Okay, it is like the three segments: hip, knee, ankle. Okay, if one is not present, the other two will work. If all three are there and we know our roles, then we do an optimal functioning where the energy efficiency will be maintained in the body. So if there is poor flexibility in the ankle, it can either affect the foot or it can affect the knee also. And it's not necessarily that gastrocnemius, because there is another muscle which is soleus. We think calf muscle, but we need to differentiate these two because they are functionally different. Soleus is a stabilizer. Gastrocnemius is a mobilizer. Gastrocnemius crosses the knee joint, so it can have influence on the knee, whereas soleus cannot influence the knee joint. And if whenever we are training a patient tells symptoms on walking. So that means our training has to be walking. Our training has to be in weight bearing. Otherwise, you are not actually making the patient normal. Okay. Severe pain, extreme conditions of pain, you know the pain mechanisms come into play. When that is come, it's constant pain. Throughout the day, it's paining. Night pain is there. Then you have come to that central perspective, or you palpate the regions for autonomic dysfunction in the heel. Okay. Whether there is any hyperalgesia or allodynia, then you think about it is autonomic dysfunctions. Then come to nociceptive mechanism or neuropathic mechanism under the peripheral. So you do a neurodynamic test which will confirm neuropathic mechanisms, and then symptoms across the segments. From the heel, the pain goes to the leg. From the heel, the pain goes to the great toe. You always know that it is neural is there. Myofascial obviously differentiated by contractions. So whenever you are palpating, you just contract a muscle isometrically. If the muscle is the problem, definitely the pain will increase. So these are simple differentiation tests which pathomechanically you can use, because you know muscles are meant for contraction. So use the contraction for diagnosis. But most of the times what we do is we get a heel pain, we get a tenderness in the medial tubercle of the calcaneum. Okay. We just see that, okay, at the bony attachment it is tender. Okay. But we don't differentiate. Okay. In our plantar heel pain course, we have shown multiple differentiations, how to differentiate a plantar fascia tenderness, flexor digitorum brevis tenderness, flexor digitorum longus tenderness, and then even the long plantar ligament, short plantar ligament, or the flexor hallucis longus tenderness, what and what not. Okay. Or even the tibial nerve, because tibial nerve also enters into the heel through this only. Here is the tarsal tunnel. So tibial nerve comes like this and then goes medial plantar, lateral plantar branches. So nerve tenderness also. And including one of my lecture in IAP conference at Bangalore, where I have done on the heel pain and then arthro-myo-neuro manual therapy, which is like articular, myofascial and neural dimensions. So we palpate the heel and we might do an SLR together, because to differentiate the tibial nerve. So many things have to be, the knowledge of differential diagnosis is not just anatomical, it has to be functional. So what is the action of these tissues? Okay, how to test them? And that active tissues versus passive tissues. Like plantar aponeurosis, we might think that it is a passive tissue, but it is a fibrous expansion of the gastrocnemius. Same like how the palmar aponeurosis is from the palmaris longus. Okay. Same way it is. The only difference is it's getting the insertion at the heel, and after that the fibrous expansion continues. So at the heel also there is a bursa called as the retrocalcaneal bursa between the tendoachillis and the bone. And tendoachillis comes here expanding into a fibrous, okay, over the periosteum. Even periosteum itself is a fascia, and then it reaches the sole of the foot. There are many variations in muscle attachments, bony prominences, the fibrous anomalies. Anything can happen in any subject. So that is why I always tell, don't trust the anatomy, because there are anomalies in every subject. Okay. So always trust the pathomechanics. So that means what exactly is the problem in the patient? As you highlighted that the prolonged standing, you know that it is the sustained loading, okay, a prolonged standing. So that is compression. That is the pathomechanics. And that patients you can tell that obesity can increase the symptom because it is to do directly with the compression. Or even footwear, the heel part of the footwear, if it is very hard, that can affect during the prolonged standing, not during the walking. Okay. So there are various aspects which we need to expand our thinking process. And today's session definitely you know that it's an overview process. Okay, to make you know that what are the things we have to upgrade in your pathomechanics. Okay, and if a footwear is having a poor flexibility, that means you will twist the footwear and see, or whether the footwear bends or not, the sole of the footwear, whether it bends or not. That actually is important for the heel off, not the thickness of the sole. The footwear sole is hard means it will not cause plantar fasciitis. Okay, it will cause the calcaneal fat pad syndrome. So even a footwear type, how we are assessing, and even pointed footwear versus the ones which is open toes. Okay, because the great toe gets towards the second toe, we tell it as the hallux valgus. Okay, when that happens, automatically here the arch will be pulled. Pulled in the sense the plantar fascia will become taut. It is elongated. Among the people who have listened to many of or attended the pathomechanics course of AOMPT before, you would have seen that every problem in lower limb, we always concentrated on the foot. Whenever the symptoms of the patients come in closed kinematic chain. So patient has problems in sit to stand, stair climbing, walking, squatting. Definitely without evaluating the foot, you cannot treat the hip. Because that is the supporting base. If that is proper, why the hip problem will come in squatting? Okay. Even sacroiliac. If I mean that squatting is the primary cause for the symptom. Okay. It's not like patient has a kind of pain in supine lying and squatting is difficult. Okay. So that means primarily we are thinking about squatting as one main factor or standing, prolonged standing as a main factor. So then we observe the foot at any moment. The foot can appear to be normal in the arch, or it is flat, or it is high arched, but that hardly matters how it is there. Because what we want is dynamically what happens to the arch. And arch also, we often look at the medial, the navicular height. That alone is not a measure of foot alignment. That is only telling about the midfoot. Midfoot is the navicula. That is whether supinated or pronated. If navicula is higher means it's supinated. Navicula is lower means it's pronated. You call it as pronated foot or you call it as flat foot. The only difference is pronated foot is used by physical therapists. Flat foot is used by patients. Okay. So avoid using the term flat foot. Okay. As a therapist. Okay. And the next one is rear foot, midfoot, and forefoot. So these three segments try to distinguish. Rear foot is calcaneum and the talus. Midfoot is navicula, and then the cuboid. Okay, both this. And the forefoot is of course, from the metatarsal to the phalanges. The other tarsal bones are anatomically part of the midfoot, but functionally they are part of the forefoot. So in that sense, if you say the calcaneum and the talus has rear foot with the tibia also has a rear foot, because functionally it is all are interconnected, all the three. Okay, anatomically not the rear foot, because tibia is part of the leg. Okay, the same way here also it is in the middle part of the foot between the rear and the forefoot. So all the rest of the tarsal bones, the three cuneiforms and the navicula and the cuboid, all will become midfoot anatomically. But functionally, if you see, the supination pronation of the midfoot is done by navicula or the cuboid only. The cuneiforms actually just to follow the navicula and the cuboid. It's like the hero and the heroine dance, and then the group dancers dance in the behind. No? So like that, the cuneiform is like that. Forefoot, it is what I can say is it's determined by the intrinsic muscles. Okay, because the intrinsic muscles are originating from the metatarsals. Okay, so you do intrinsic muscle strengthening. That means you are addressing only the forefoot. You do gastrocnemius flexibility, release, or whatever strengthening. Definitely, it is going to address the rear foot. So what are we doing conventionally is arch is flat. We see a high incidence of people with plantar heel pain or plantar fasciitis in a common condition. Okay, maximum cause of plantar heel pain is plantar fasciosis or fasciitis. So in that you see pronated foot is there and patient is having the heel pain. So we always treat the forefoot and rear foot and we leave it. But the actual problem is the midfoot, which we do not address. And we think that dorsiflexors like tibialis anterior will maintain the arch. The mistake what we are doing is it's a closed kinematic chain. So concentric activity of agonist will not be there. Dorsiflexion is not but done by dorsiflexors. When it is weight bearing and then dorsiflexion is happening, it is done by the eccentric activity of plantar flexors. So kinetics part, always remember that when it is in weight bearing means always it will be eccentric. So don't go by the agonists which are given in the anatomy textbooks. Go to the antagonist and see that they are eccentrically working. And among them also, you want the gastrocnemius to work eccentrically. Okay? Eccentric contraction is always a property of stabilizer muscles. So ultimately we come to the soleus eccentric. Okay? So that is the picture there. Other than that, for the midfoot or the navicula, there are two more muscles attached directly on the navicula. Of course, other than the tibialis anterior is tibialis posterior. The one muscle which is a kind of an underworld dawn, because it's not that obviously distinguished or identified or everybody blames, but that dawn is the kingmaker. He decides whether it is like how the gastrocnemius is going to operate, and the tibialis posterior, because tibialis posterior is a synergist to the gastrocnemius. Okay, it is also posterior compartment of the leg. The only thing is it changes directions, like from posterior to medial in the tarsal tunnel, and it comes below to the navicula. Okay. Tibialis posterior dysfunction as a cause of heel pain is also widely reported in the literature. That is dysfunction. That is tibialis posterior dysfunction as a cause of the heel pain. Okay. So that means we are not expecting that it is injury of the tibialis posterior. It is a dysfunction of the tibialis posterior. Injury comes in other structures. It can be plantar fascia or it can be even flexor hallucis longus. Why flexor hallucis longus? Because it is just coming next to the plantar fascia, all along the medial border, tarsal tunnel, and posteriorly. So it is like your friend does the mistake and you get the slap. So it is like the pranks which they show on these reels. So it is not doing anything much. But if you see the mechanics of plantar fascia, how the literature defines, okay, two mechanisms. One is the windlass mechanism, which is like extension of the great toe. Okay, you extend the great toe, it pulls the plantar fascia anteriorly or increases the tension in the plantar fascia so that the arch raises. Okay, So the bottom, for example, like a balloon-like membrane in the bottom, you pull that, what will happen? The dome will increase. Same like diaphragm also. You actually approximate both the lower ribs, diaphragm goes up, okay, like doming. So say that is the windlass effect. So that means you get a great toe extension, so it pulls the plantar fascia, and plantar fascia is attached to the heel, so the arch raises. This mechanism operates in the heel off, where the great toe is placed, and then you are having that pull so that the arch is increasing. Especially why in a heel off we need the arch to increase? It's because whenever the arch increases, it becomes a supinated foot, and that supinated foot is important for propulsion. That means to get the force from the ground all across to the body. Okay, so if an athlete, for example, you have seen that how they start the race, if they are a sprinter, they stand in the heel off only, and then they give the propulsion and then they go. Okay, so it is efficient. Foot is effective for transmitting the forces to the knee and the hip if the foot is supinated. Okay, so that great toe extension and the windlass mechanism maintains that foot to be rigid or strong, so that the propulsion can come from the ground and the ground reaction force can give the momentum for the person to run. On the contrary, the opposite of the mechanism, the second mechanism of the plantar fascia, the first mechanism is responsible for the early morning symptoms, where you keep the foot down, okay? You don't get the pain on heel strike. You get the pain on heel off, okay? Heel strike, if the pain comes, it's totally different. I want you to understand that. Heel strike, if pain comes, it's calcaneal fat pad syndromes, okay? You don't think that it is plantar fascia, or both might coexist, okay? But remember that which one, what, how to be treated. If, for example, the other alternate mechanism which I was about to tell is the wedge and truss. Wedge and truss mechanism. Most of the people biomechanics are UG curriculum. Many people explain only the windlass mechanism and they forget about the rest of the pathomechanics. But if you see that wedge and truss mechanism is important for the force that is generated from the body towards the ground. A windlass mechanism is transmitting from forefoot to the rear foot. Okay, so it's an anteroposterior. And that makes the foot to be supinated so that propulsion comes. Wedge and truss mechanism is the vertical or the body weight. And because of that, this can flatten because the truss is pushing. If the truss is not pushing, it can supinate. Okay, so this is an articular or skeletal, okay, which is predominantly dependent upon body weight, or maybe athletes who are landing, for example, hurdle runners. So you jump and then you land. Definitely that will have the wedge and truss effect to be maximum. Or even when you are skipping, although you are only on the toes, the maximum impact is the truss that is on the wedge. Okay, so and that influence comes to the rear foot, primarily rear foot, because along the tibia is the rear foot. Tibia is not on the navicula. Okay, talus, that is why it is uniquely shaped, so that it can distribute the force anteriorly. If talus is just like any other bone, like a cube, okay, all the force will go to the calcaneum. But because it is having that neck, body, and it's a unique shape it is having, and because of that, the force goes to the midfoot, okay, from the talus to the midfoot, okay. So it's like a zigzag, a shape like that it is having. So it comes like this to the midfoot. So if I have told about the two scenarios in the plantar heel pain, the calcaneal fat pad syndrome on standing versus plantar fasciitis or fasciosis, which is on the heel of standing and heel strike versus the heel of and improper footwear, walking uneven grounds, then only symptom comes. Overuse symptoms cannot be a fat pad syndrome. Sustained forces only will create fat pad syndrome. Repetitive is the one which is for plantar fasciitis. The next one, whenever fat pad syndrome comes, that means the tissue is here. You have various reasons of the fat itself being less. The sole of the foot, the fat is less, or the heel of the footwear being very hard. High heels, what we talk of, okay, will actually cause the fat pad syndrome because the full load is on the heel from the ground reaction force. Okay, body weight goes to the metatarsal. Okay, so it creates a kind of an imbalance. The heel actually produces the ground reaction force in the high heels. Okay, and there the impact will be on the calcaneal fat pad because that is the cushion. The body weight goes anterior to the forefoot. People develop even stress fractures of the metatarsals, okay, because of even ballet dancers, okay, they dance on the toes, okay. So, or they even this high heels also, the metatarsal will be getting the loaded, okay, the full load from the body weight. So this only creates the imbalance, what we tell it as the line of gravity being much more anterior. Normally, if the line of gravity is just in front of the talus, the high heels footwear will make it to be either at the navicula or at the cuneiform. So it's a huge shift of the line of gravity anterior, with impacting fat pad passively, and when the patient walks, it is the metatarsal that will be loaded. Wedge and truss effect, where the force fully distributed anteriorly. Okay, standing, all the force will be distributed to the posterior. So patient wearing high heels also, you have to ask whether pain is more on standing or pain is more after walking. You can't just like heel pain is there, high heels is there. Okay, there was a situation when the musculoskeletal Jammu, one of our member, she was telling us that she has heel pain with the high heels, but she wants to wear that high heels because it is the important one to match her dresses, the suits, okay, for the parties and the evenings. So then we know the patient's concern are like this. You cannot tell them not to use the high heels. If someone comes with a problem that I have heel pain because of high heels whenever I wear, I have heel pain, treat me. You cannot tell them don't use high heels. That is not a treatment. That is only avoiding the forces. What is the treatment which I did, which the patient felt better? In one session itself, she was able to use the high heels and walk around. Okay. It was because I modified the calcaneal position. Indirect modifications. So here calcaneal alignment, which is varus or valgus. Varus and valgus, calcaneovarus, calcaneovalgus means inverted and everted calcaneum respectively in the weight bearing. So in the closed kinematic chain or weight bearing, calcaneal inversion is called as the varus, calcaneovarus. Calcaneal eversion is called as the calcaneovalgus. So what causes the calcaneovalgus and the varus? That means it's the eccentric imbalance of the opposite muscle. You can't tell tibialis muscle or tibialis posterior overactive, so it is inverting. No. Okay, because it's agonist for the inversion of the calcaneum. You have to tell peronei eccentric underactivity, so calcaneum is inverting. Because antagonist muscle controls the weight bearing, the closed kinematic chain. positions. And this is to do with stability. So you want that eccentric control. So if the heel is pronating, heel is going laterally, which is calcaneovalgus, it means that tibialis posterior eccentric underactivity. Okay. As a shortcut, as a preliminary or as beginners, you can relate. This time, this is the borderline where you will get about to get confused. If at all, till now you are not confused. Okay. Remember that because concentric and eccentric itself, shortening, lengthening, contraction, then overactivity and underactivity is there. Okay. So here we know weight bearing closed kinematic, so it is eccentric underactivity. So the bone is going into opposite direction. Till here it is fine. Even in our master classes, practical master classes, when I have taken multiple times, people don't watch the videos again because more and more you watch, more it will confuse you. Okay, that's the only thing that will happen. Okay, not that which you have taken, the one which I am telling for heel pain and ankle sprains. So especially to do with the foot, because there is a course, lower extremity kinetic kinematic chain integration techniques, Lexit. It's only 6 videos. Total duration of all the videos, I don't remember whether it is around 3 hours or 4 hours. But that is definitely after that 6 videos, every foot mechanics it will be easy. So something here and there is a separate field called as podiatry. They concentrate on rear foot, midfoot, forefoot, and their alignments, static and dynamic, in open and closed kinematic, with respect to kinetics and kinematics, where muscle activity is concentric, eccentric, overactive, underactive, shortened or lengthened muscles. Okay. So we have two acronyms which we tell it as CUT and LEO. Concentric underactivity present in tightness, CUT. A LEO, eccentric overactivity present in lengthening. So lengthening with eccentric overactivity, LEO. Concentric underactivity with tightness. Okay. So this is like tight muscles, which is like you are expecting gastrocnemius to be tight. It will be concentrically underactive. So that is important for running. That's important for sprinting. Okay. You don't want eccentric, concentric for normal walking. Okay. Gastrocnemius concentric. Okay. But the same way, if you have tibialis posterior tightness, see gastrocnemius tightness, that is the one. Tibialis posterior tightness, it will not actually lengthen, correct. But lengthening of tibialis posterior, we don't actually require that much. Flexibility of tibialis posterior, we don't require much. All we want is a good eccentric control. Because tibialis posterior, eccentric weakness is the reason for the rear foot pronating. That is calcaneum eversion. Okay, so tibialis posterior, eccentric underactivity. So when we know this pathomechanics, then definitely we will train the tibialis posterior for motor control. Whenever motor control you train, it means that there is a cognitive participation, a learning effect. We train muscles which are stabilizers. We activate them. So that is like soleus, which is one stabilizer. Other stabilizer is of course the intrinsic muscles, but that's for the forefoot. Yes.
It's clear, ma'am.
That must be in the individual problems. Because if there is anything disturbance, first thing will be Ritu ma'am is like, sir, you are not visible. Sir, you are not audible. Immediately she'll tell.
Sir, it's perfectly fine.
I think Janya is reconnecting. Sometimes what happens now, even if the net notification comes, or a call, missed call, anything comes, any notification which is like this comes na, here this becomes, volume becomes muted.
Slow.
Yeah. So you are at a juncture where stabilizers activation is important. So I'm telling treatment implication for the pathomechanics, because we understand the pathomechanics means what do we do next. So that means training the tibialis posterior eccentrically is important for the calcaneum which are everted in the weight bearing. Okay. Do not just train the intrinsic muscles of the forefoot and leave that, or stretch the calf instead of treating the. Of course, if you are the best police officer, means you will arrest the don. Okay. But that happens only in the movies. In reality, the don is the tibialis posterior. So you have to arrest. You have to train them. Then only the whole foot becomes. Because tibialis posterior controls the calcaneum through tibia and controls the navicula because it is attached. So insertion is actually in the navicula. So it can easily control the navicula. And origin is in the tibia. So it controls the tibia. And also, you know, closed kinematic or weight bearing, it is always the origin. The higher tibia only moves. You don't get an inversion eversion because calcaneum movement. You get an inversion eversion because of tibia movement. Okay. Which may be mediolateral, or it may be the rotation of the tibia. Okay. Internal, external rotations, which can also affect, because we have seen that external rotation of tibia. I think I'm going to dislocate this knee joint. Okay. So if internal rotation of tibia will evert the calcaneum, external rotation of tibia will invert the calcaneum individually in weight bearing. So that means an internal rotation of tibia, why it happens in weight bearing? That means external rotator is eccentrically weak. So that means it can be iliotibial band, eccentric weakness, or biceps femoris. They both are external rotator of tibia. Their eccentric weakness in weight bearing will create tibial internal rotation, creating a calcaneum to go everted. This is standing symptoms or high heels. Okay. So think that how pathomechanics can give you a direction. If it is heel pain where it is static, heel pain that is dynamic, heel off, and see that when it is dynamic, when someone has walking and then after that getting heel pain, like a overuse, which is the typical initial progression of plantar fasciitis. Later it becomes like with less activities also paining. Although diabetes is also associated with that, uric acid, high levels in the body. Okay, metabolic reasons are many, but mechanical factors which influences. Okay, the pronation of the foot makes the plantar fascia to take all the load. If it is supinated foot, the forces goes to the knee and the hip. So this pronation of the foot, why it has come? Whether the subject has generalized hypermobility. Women generally have the pronated feet because their joint mobility is more. Okay. Maybe because of ligaments, hormonal imbalances and all this, and physiologically their mobility is more. So it doesn't matter that you have to say that it's a pronated feet I have to treat. It's physiologically normal. The woman had the same pronated foot for 25-30 years. Now she is having plantar heel pain on walking. And that pronated foot is both the sides, it is pronated. As I was telling, gastrocnemius is tight both the sides equally. One side is heel pain. Will you stretch the gastrocnemius? Because both the sides it is tight. It's physiological tightness. It's not pathological. You have to see that what is that difference in this side. Treat the difference, don't treat the similarity. one heel pain, you are giving one patient, you are given one treatment because tibialis posterior trigger point was there, you released it. Okay. After that, the eccentric activity would have improved in tibialis posterior without giving training also. Okay, so you will feel like I have released the gastrocnemius because we have not checked the action of tibialis posterior. So tibialis posterior does the plantar flexion and inversion of the foot. So do we resist this contraction and check when we are palpating the trigger point? We check that action? No. Do we do the heel raise? And during the heel raise, do we see that the calcaneum is it everting? That is the tibialis posterior tightness test versus tibial calcaneum inverting during the plantar flexion. So heel raise when you do both sides, or unilaterally you do to provoke more. If it is like not visibly found in bilateral weight bearing. We do some treatment, patients have been improving, does not mean that the treatment is actually effective unless and until we get the reasoning behind how that improvement came. For every pain relief, definitely pain mechanism will operate. Through the mechanisms we can answer even placebo to peripheral effects or autonomic. Definitely a heel pain that is constant, you want the plantar fascia to heal, there is inflammation, you percuss, pain is coming like pricking pain, you touch, the patient is telling burning pain, allodynia. Definitely you can use sympathetic or the parasympathetic interventions. Okay, what we have demonstrated in the pain mechanisms. So remember on whom which approach has to be used. Rear foot, forefoot, you will go only when it is peripheral mechanism. Otherwise, you will treat the central and autonomic. A central mechanism typically can be identified also by if a patient is telling I'm, for example, like you can deviate, you can make sure that standing, for example, heel pain, make them to stand in the water, aquatic therapy. When even water is still the mid tibia, not like neck and all. Okay? Mid tibia alone water is there also. You have eliminated at least 10% of body weight or 5% of body weight you have reduced. Standing is heel pain. But the patient will tell there also inside water standing also heel is paining. You know that it is central mechanism because standing heel pain central. Okay, that is here, not in the heel. Okay, so these all things are the same way. Walking heel pain, you make them to walk backwards, no heel pain. Understood? Muscle activity is almost the same whether you do forwards or you do backwards. Only the phases are different, but the muscle activity is the same. Okay. For example, that toe off will come first. That is like touching. Okay. Heel off will come as heel strike, toe strike. Okay. Instead of heel strike. So these things will happen. I don't think there's a biomechanics literature telling backward walking biomechanics, but pathomechanics also. But many research have proven that backward walking is effective for osteoarthritis knee. Backward walking is effective for post-traumatic stiffness ankle. Okay. Lot of, you just search in PubMed or you search generally in Google Scholar, backward walking and then articles, you will get numerous articles. Backward walking is beneficial. How all these researchers start about backward walking? They just thought the whole world is going forward, let's go backward. We don't know. Okay. But because just for a difference, okay, I have to do something different. Then only I am a researcher. But remember that the difference has to come benefiting the patient. So first thing is you go with what is the mechanics, analyze, do the motion analysis, and then come back with the clinical trials. But unfortunately now randomized clinical trials are more explaining the basic mechanism. Even in the article discussion, it is absent. Okay. So you try to see that when it is walking producing heel pain, whether you do forward walking or backward walking, the heel pain will be same. That is central mechanism. But if it is like forward walking only is memorized as heel pain, that means backward walking will not cause the heel pain. So the similar way, muscle activity, peripheral cause is there, both will pain. Forward and backward has to pain. Okay. So different aspects you can explore, and most importantly, release of the plantar fascia. Remember that great toe extension is important, and then flattening the anterior transverse arch is important. Fixing the calcaneum is important, because without stabilizing the calcaneum, you do elongation of the fascia, it will go into inversion or eversion, and then you will be. And many people think that plantar fascia is stretching. Never. It is not stretching. Fascia cannot be stretched. It is only unfolding of the fascia. So fascia is like a sheet folded. You are unfolding it. The length is same. Okay. It's not plantar fascia stretching. Do not use that term. Those are used by athletic trainers, not by physical therapists. Okay. So release also, it is you are releasing the plantar fascia from the underlying adhesions. Because if adhesion is there, the fascia won't be gliding or unfolding. So to remove the adhesions, we do the local cross fiber massage in athletic training. In celiacs, we tell it as deep transverse frictions. Either you do from the top or from underlying surface of the plantar fascia, because you want to lift the fascia. But give the treatment in the heel of face. So make the subject to stand in the heel of position. In the heel of position, you make the patient to stand, then you do the treatments. Don't do supine, prone, knee bent, keep the foot like this, and then treat the plantar fascia. Understood? So, I hope you are getting some amount of directions, because this webinar is actually not for training people. It's not for empowering physical therapists to actually do the treatments. Okay. This is an understanding. And this webinar again is a part of the series of 25 webinars where it's emphasizing on one thing. Mainly it is for the Kolkata COMT, because we have the every disorder, regional, all the disorders and the dysfunctions come. So before that, the regional pathomechanics is important. And then next we come to the batches announced in Pune and also in Bangalore, where the pathomechanics 2 days courses. Okay. So for that, as a preliminary or an add-on study material, let these discussions cover the theoretical part, so that practical demonstration, when I suddenly keep a wedge under the calcaneum, medially I keep the wedge, laterally I keep the wedge, and I make the calcaneum to be everted or inverted, and I recheck. That means what is the pathomechanics? So that is the calcaneovalgus varus. So there, where which one we are treating, and which is physiological, which is pathological, how to distinguish between rear foot dysfunctions versus forefoot, midfoot, whether are we treating the tibialis posterior, which is a culprit. And when we see now lateral ankle sprain in the twin webinar today, the next, when we begin subsequently after the summary by Dr. Sujanya, you will see that the contrast between both this, because plantar heel pain is a pathomechanically hypomobility dysfunction, whereas the lateral ankle sprain is a hypermobility dysfunction. So it's total. And in the other way, plantar heel pain is a pronated foot dysfunctions. Lateral ankle sprain is a supinated foot dysfunctions. Okay. But in the human body, if a rear foot is supinating, midfoot can pronate, or rear foot is supinating, forefoot can pronate, and they will try to support each other. Okay. So we will resume now the second part after Dr. Sujanya's summary. Yes, Sujanya, go ahead. I know it will be like a foot and ankle. Yeah.
So I joined in late, but since I have joined, I think this is really a great insight for a teaser for knowing what you need to be prepared for the courses that you're going to offer. But also, I guess I say this in every video of mine. With the clinical practice, treatment is the easiest part, but trying to know what the culprit is and aiming to that particular culprit will give you faster results and accelerated recovery for the patient. So this is where I guess understanding the real actual biomechanics of the body. So underactivity, overactivity, the agonist, antagonist mechanisms, and the concentric and eccentric work. It's very interesting if you are quite thorough with your lower limb biomechanics during walking, during every phase of walking. It makes your evaluation assessment go really so narrowing down to that particular culprit that you can give a very streamlined exercise for it and treatment for it. So this is where I guess a lot of physios fail to find out the real problem in the foot. As you said, the complex is involved, the hip, knee, ankle complex and the foot complex. It's involved. So where they get diverted to podiatrists who are very thorough with their.
I somehow intentionally avoided using the word complex because the moment we tell that, the central sensitization comes in the viewers that it is a very complex. Okay. So the biomechanics, the problem is shoulder complex, elbow complex, wrist and hand complex. Okay. Like this, they keep the names. So automatically we think that biomechanics is complex. Okay. And we develop infinity complex.
I guess I don't know if the term is changed in the textbooks now, but I'm also an old school, so I'm used to the word complex. It never alarmed me, but it was just interesting to know. It is. I think the curious minds will unwind the mystery of the complex. So it is good to unwind that mystery because everything matters. All these little muscles and tendons that are, adding to those forces and responding to the ground reaction force.
As I can vouch that knowledge that is not complex cannot be what is called as the real knowledge. Okay. But the glory of it is to simplify it when it comes to education and we clinical practice application, everything we simplify. Okay, so then we use it. So it goes. Yes.
Yeah. So quite interesting. I just have to. I think I have lost my track with the calcaneus varus valgus in weight bearing. Probably it's getting late, and also it's in my clinical practice. I have not done much of an evaluation or analysis on this area. Although I have worked on the tibialis posterior and balancing the activity, underactivity and all, but I guess I just need to add this component into my evaluation to just make it a bit more pinpointing towards my my assessment. So that will be interesting, something to work on this week. So thank you for mentioning that in this training. Yeah.
Have you tried this wobble board for plantar heel pain?
Yes.
Okay.
Yes. Wobble board, I have.
Eccentric.
Yes. Yes, for eccentric working, yes, done wobble board. We've done the wedges as well. So actually, the person's not standing in dorsiflexion. How do I say this? Complicated. We try and, as you're saying, the wedges. You place the little wedges around under the foot.
Heel.
So we place the bigger wedge. Okay, so the whole bigger wedge is in such a way that the whole foot is inverted in an angle, and then we do the catch and throw ball and other neuromechanical work, so to improve coordination and proprioception around the ankle.
The medial longitudinal arch itself.
Yes, the whole foot. The whole foot is in an angle.
Means heel also?
Yes.
Okay.
Okay. So but that will be a bit more in a broader perspective, and it comes later in the recovery of the ankle.
Kind of a neurological, like foot is totally, all the rear foot, mid foot and forefoot are pronated. Okay. If all three are pronated and you feel like they cannot supinate themselves, okay, so you want to keep the supinated position with the wedge and then do a balance or activity training like that. Okay.
Yeah. So just trying to make it a bit more not complex. I'm not going to use that word.
Forefoot, all three are pronated, then it's very difficult to train the knee. Knee will go into valgum or crouching. Okay, like cerebral, the spastic diplegics.
Yes.
So for training knee and yes.
So it is just to give them that idea of or a motor relearning for how that whole foot will feel. Just to get that proper. Yes. Yeah, but not a long time training in that. It's just to give that quick burst of feedback. So those things will actually, this evaluation would really help me understand that why it worked, why it didn't work, for that patient. So this is something I need to look into. Just going back to biomechanics and pathomechanics, it's been a while I have revised that. So this was a very good session today for me.
Okay. So let's see if you are rejoining back as per Ritu ma'am, what she says. And if you are also feeling like, let's end the day today, we have known something, it's enough. Okay. Then definitely we can do the lateral ankle sprain tomorrow.
Yes.
Okay, it's fine.
Yes, if it is possible. Yes.
Yeah. Let's see, check with madam also, and then we'll do that.
My left eye is trying to.
We'll do it when we are the best. Okay.
Yeah. Thank
not
you.
Like a big time forced schedule we are having anything like that.
No.
Okay.
No,
So but because learning has to be the most enjoyable experience, and it's the rejuvenating of the brain. Okay, when you are recharging the brain, you should feel like when the battery is not having the distilled water, what is the point in charging? Okay, so we need to actually take care of the battery.
Yes.
Okay?
I had a long day, so sorry about that, but
So we can meet again tomorrow, and we can do the lateral ankle sprain. Subsequently, we can do the knee, no problem.
Yeah.
Okay?
Sure.
Because
Thank
madam
you.
also having recovery from the fever and medications and things, so she also
Internet
also slow for her, so it's fine. Okay?
No problem.
We don't want her to be roaming around outside her home for the Wi-Fi, neighborhood Wi-Fi, and after that mosquitoes will bite her. Yes.
Sir, a quick question. You mentioned about those 6 videos of the foot. Which course is that?
Let's see.
You can.
Lower extremity kinetic kinematic chain integration techniques. Okay.
Kinematic chain integration. Yeah, I'll have a look into that.
Those videos you can take it for free because this is now under the August offer that there are option 1, 2, 3 and people can take any one of these options and they can avail free courses from the AOMPT. Okay. So let it listed under the list of free courses. And
okay. Oh yes, the awesome August post. I saw that one. Yes.
Yeah. You saw it, but you didn't read it because you were with the patients. Okay.
Today I had a very hectic day, so I did not. I still haven't opened my WhatsApp messages. There's like 1,000 messages sitting there.
Yeah. Okay. So let's say bye bye and wish ma'am also, because madam's interest, the foot and ankle,
Yes,
so we held it. We'll also keep it tomorrow for the lateral
sure.
ankle sprains then. Okay.
Thank you.
Hope that today we don't sprain ourselves. Okay. Right.
All right. Thank you.
Good luck. Yeah.
Good luck, sir. Thank you. Bye, ma'am.
Mhm.